Many oncologists believe that the gold standard for proving that a new drug is effective is a randomized clinical trial demonstrating a statistically significant improvement in overall survival or life expectancy of the new drug compared to a standard therapy. Furthermore, the Canadian Drug Agency and similar groups in other countries may use a gain in overall survival as a metric on which to judge the financial value of a new drug. I will discuss in this video why my perspective differs from this. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book on cancer called A Short Primer on Why Cancer Still Sucks, available through Amazon Books. Gain in overall survival with a new drug is very important, but the estimate of gain in overall survival based on a clinical trial can be highly unreliable. For a new drug to be deemed to be effective, the gain in overall survival has to be what's called statistically significant. Simply put, the statistical analysis must indicate that there's a greater than 95% probability that the observed gain in overall survival is real and not just due to chance alone. In a later video, I will discuss some of my concerns about how clinical trials are run overall and how statistical analyses are done. In this video, I'll discuss why the clinical trial endpoint of overall survival gain carries a high risk of erroneously discarding some effective drugs based on problems with the interpretation of clinical trials. There are two major reasons that overall survival gain in a clinical trial may be an unreliable indicator of drug benefit. The first factor is crossover. By crossover, I mean that patients initially assigned to the standard therapy are crossed over to receive the new drug when their cancer progresses on the standard therapy. The second reason is based on the impact of subsequent therapies that may be given to patients after their cancer progresses on the initial therapies they're receiving as part of the clinical trial, and how these subsequent therapies may color the statistical analyses. First, I will discuss crossover. In an analysis we did of new cancer therapies that significantly delayed progression of a cancer compared to standard therapy, if more than 20% of patients crossed over, this cut in half the probability that the overall survival gain would achieve statistical significance. Crossing over to a new effective drug would improve the survival of patients in the standard arm of the study, and this would decrease the apparent difference between patients in the standard arm and those in the arm receiving the new drug. This can erroneously make a new drug look ineffective simply because it is improving outcome in both arms of the trial. And based on erroneous conclusions, an effective new drug may be discarded and lost. Let me use an analogy of a mythical island kingdom in which many inhabitants accidentally fall off the cliff into the surrounding water. And it would be a normal reaction if they fell off the cliff into the surrounding water that they would begin to try to swim. However, true believers in the importance of randomized clinical trials to demonstrating the benefit of a therapy would say there's never been a study that shows that swimming is actually of any value. So they set up a randomized study where people falling off a cliff would be randomized to those who are permitted to swim and those who are not permitted to swim. The only problem is that many of the people that are randomized to the no swimming arm cross over when they realize they're about to drown, they begin to swim. Since many of the no swimming group crossed over and began to swim, therefore the number of survivors in the no swimming group goes up quite a bit, and that decreases the difference in number of survivors between the swimming arm and the no swimming arm, and hence statistical significance is not achieved. There are a few options with how to deal with this. One option is to say that it's obvious that swimming is helpful and that from now on everybody should be permitted to swim. However, many true believers in the importance of a randomized clinical trial with a statistically significant overall survival outcome will disagree. They will say that the demonstration of lack of a difference between the two groups proves that swimming is of no value, so nobody should be permitted to swim. The second option is to run the trial again, but this time prevent crossover. Handcuff the no swimming group so that they cannot swim. This convincingly proves that swimming is effective, but to many of us, forbidding crossover to therapies that are potentially effective is unethical. The third option for many true believers would be to just repeat the trial with a far larger number of people participating. There was some observed difference between the swimming group and the non-swimming group, but because of crossover, just not enough to achieve statistical significance. The way that statistics work, the higher the number of participants in the study, the higher the probability of statistical significance for a given size of a difference between the two groups. So a new trial is launched and a far larger number of people are accrued. But unfortunately, most of the participants know that swimming is going to help them, and so the vast majority of the non-swimmers cross over to begin to swim. So even though there were far more people in the second study, even though the number of people surviving in the swimming arm surpassed that of the non-swimming arm, because of the large amount of crossover, there was insufficient difference to be able to achieve statistical significance. So the true believers, the lack of statistical significance in the later larger study just confirms the other study that swimming is of no value and people should not be permitted to swim. All these true believer potential actions actually do happen in the real world. Some proponents of the use of an overall survival gain as an indicator of drug benefit do advocate discarding drugs that do not demonstrate a statistically significant improvement in overall survival gain, despite a lot of other evidence that these drugs are effective. Also, to improve the probability of achieving statistical significance, people do advocate launching clinical trials in which crossover is forbidden, although I and many other people like me do think that this is unethical to do this. When a drug does appear to be effective but fails to achieve statistical significance, true believers have advocated increasing the trial size. But such large trials often fail because many people do recognize that the new drug is actually effective. Patients want the new drug. They do not want to be on the control arm. So they may possibly participate in the study if it's the only way that they can get access. So they're coerced into participating in the study to get access to it. And they play the lottery hoping that they'll be assigned to the arm with the new drug. But if they're not assigned, they may drop off early and cross over. From my perspective, the problem is that the belief in a gold standard, like an overall survival gain that achieves statistical significance, is not really a scientific endpoint. It's more like a religious belief that is cloaked as science. Despite being flawed and highly unreliable, such gold standards are regarded as being the truth against which other endpoints are judged. If the other endpoints disagree with the gold standard, then the other endpoints are deemed unreliable, even though it is actually the gold standard that is unreliable. It's like the church's belief in the 1600s that the sun revolved around the earth, when they convicted Galileo of heresy for instead saying that the earth revolved around the sun. Galileo's conclusions went contrary to the gold standard of the time. Overall survival of the new drug is important, but available data demonstrate that if there's even very modest crossover, that decreases the probability that the overall survival gain will achieve statistical significance. Now, true believers might say that my swimming analogy is unfair and that they would never throw people into the water just to prove a point, and they are correct. What some do instead is say that patients who are suffering and dying from cancer should not have access to a new drug that could potentially help them simply because a randomized clinical trial had not shown a statistically significant gain in overall survival. The true believers do not throw anybody into the water, but they may try to block us from throwing a lifeline to someone who is in trouble just because that lifeline has not met their standards. You do not need a randomized study with a survival outcome to tell that a new drug is effective. If there are a high proportion of patients that have major tumor shrinkage with a drug, then that's a reliable indicator in most cases that that drug is effective. The other thing that makes gain in overall survival in a clinical trial an unreliable indicator of drug benefit is what happens if they're given additional therapies after that initial therapy. To understand this, you have to understand that the usual metric that is used to judge statistical significance is called a hazard ratio. In simplistic terms, the hazard ratio is calculated by dividing the number of surviving patients in the standard arm at each time point by the number of patients receiving the new drug at each time point. The smaller that ratio is, then the higher the probability of statistical significance. For example, if the average survival with a standard therapy was about 1 year, and the average survival with a new therapy was about 2 years, then dividing 1 year by 2 years would be 0.5, and that would be the hazard ratio for that new drug. A hazard ratio of 0.5 would carry with it a high probability of statistical significance. However, if the average life expectancy with the standard therapy was instead 1 week, and with the new therapy was 2 weeks, the hazard ratio would still be 0.5. And because statistical calculations are based on the hazard ratio rather than on absolute differences, that gain from 1 week to 2 weeks would have every bit as much statistical significance as a gain from 1 year to 2 years. But it is what happens next that I find particularly problematic. The time from therapy initiation until tumor progression is referred to progression-free survival. And let's say that the progression-free survival is 1 year on the standard therapy and 2 years on the new therapy. Then the hazard ratio for progression-free survival would be 0.5, and that would be probably highly statistically significant. But let's then say that patients in both groups live for another 4 years after that. Then the overall survival in the standard therapy would be 1 year plus 4 years, or 5 years. The overall survival in with the new drug would be 2 years plus 4 years, or 6 years. If you divide 5 years by 6 years, then the result is 0.83. That's the hazard ratio, 0.83. And there'd be our analysis of published data indicate that there'd be a very high probability that hazard ratio of 0.83 would not be statistically significant. So many true believers would then advocate discarding this drug because the hazard ratio was only 0.83 and it did not achieve statistical significance. On the other hand, they would keep the drug that increased survival from 1 week to 2 weeks because of the fact that it did achieve statistical significance. You might say that this is ridiculous, and I agree it's ridiculous. From my perspective, it's just not rational. The insistence of using an overall survival gain as a gold standard has been called common sense oncology by some of my true believer colleagues. They are well-meaning, but I disagree with them. If you look at it closely, it's not common sense at all, it's nonsense. I personally believe that we need to look at all the evidence and not just some of it. We should not restrict ourselves to one highly flawed metric. Now, the true believers will say that that's not necessarily the only metric they would look at. They would also look at the improvement in quality of life. And if that was statistically significant, they would also accept that. The problem is that assessment of quality of life is highly imprecise and subjective. And in fact, I know many new drugs do unequivocally improve quality of life. I know of very, very few cancer drugs that have been approved on the basis solely of improvement in quality of life. As I discussed in my book, A Short Primer on Why Cancer Still Sucks, and as discussed in several of our academic publications, there are better ways to judge efficacy, including the ability of the drug to cause cancer shrinkage, referred to as response, and the ability of the drug to delay growth of the cancer, referred to as progression-free survival. There are caveats and potential limitations to both of these endpoints, but unlike overall survival, they are not distorted by crossover and by post-progression survival. I will discuss the caveats and limitations of response and progression-free survival further in a later video. Many true believers claim that response and progression-free survival are unreliable because they may be positive when overall survival is negative. But from my perspective, it's the overall survival endpoint that is the unreliable one. Because of the impact of crossover and post-progression survival on the statistics for overall survival gain, effective drugs may be discarded and lost. If a new drug does yield a statistically significant improvement in overall survival gain in a trial, it probably truly is beneficial. But if there's been more than minimal crossover, we will not be able to judge the size of the benefit because of the crossover. If the overall survival benefit is negative, we can rely neither on the lack of statistical significance nor on the size of the survival benefit if there's been more than minimal crossover. Similarly, if there's been more than minimal post-progression survival, we cannot rely on the statistics to tell us whether the new therapy really does have an overall survival gain or not. We may be able to judge the size of the benefit, but not its statistical significance. And even if it's large, it will be thrown out if there's not statistical significance. Regulators, those paying for drugs, and clinicians may find gold standards very helpful. It is easy to make yes-no decisions if you can rely on a gold standard. The only problem is if your gold standard is highly flawed, like the overall survival gain in clinical trial, then you may often make the wrong decisions. We are fortunate that the American FDA, the European Medicine Agency, and Health Canada all recognize the high risk of false negative overall survival outcomes, and they look at many other things in deciding whether or not a drug should be approved, not just a single flawed metric of overall survival gain. However, other groups like the Canadian Drug Agency, which makes decisions about whether or not governments should fund new drugs in Canada, they do not appear to have as clear an appreciation of the serious shortcomings of the gold standard. And this is most unfortunate for Canadians who are suffering and dying from a cancer and who could have benefited from these new drugs, but instead are condemned to suffer and die without them. Thank you.